I am Dr. Rahman, and welcome to Black Women's Health Podcast. I'm going to tell you a true story. I was in the office with a patient, and it was at the end of the visit, and she was a young, vivacious woman in perfect health. And she said, I'm thinking about getting pregnant, but I don't know because I don't want to die. And I remember feeling shocked at that point because at this stage I had delivered thousands of babies and never had I linked the possibility of pregnancy, giving birth, to dying. But apparently this woman had. And I was reminded of this when I saw the recent McKinsey report talking about bridging, closing the Black maternal morbidity health gap, reducing Black maternal mortality, reducing Black infant mortality, reducing Black female morbidity associated with pregnancy. And unlike many studies that kind of end with, we need to do more studies, this report actually gave 5 things that we could do. 5 things. One, two, three, four, five. 5 things that we could do that would reduce Black maternal mortality. And in addition to that, they said it would improve the health for all women and be an economic boost to this country. Pretty amazing. I want to share those 5 things with you. I want to share it with you, and then I want to add my 2 cents. Number one, make the measurements standard across the board when you're evaluating maternal morbidity and mortality. Let me give you a for instance. How do you think we track maternal death? We have a death certificate form, a standard death certificate form, and on that form, there's a box called the pregnancy box, and that indicates if she was pregnant at the time of death or she died shortly after the pregnancy ended. Fields, I mean, basic box on a standard form. This was first implemented in 2003. It took until 2018, 2019 before all 50 states decided to include the pregnancy box on the standard death certificate. It shouldn't be that hard to just have standard measurements so we know that we're talking about the same thing. Are we talking about maternal mortality rate, or are we talking about a pregnancy related mortality rate? Let's not confuse the picture. Let's have some standard measures. Let's call it the same way, the same thing. That's evaluated the same thing. And then let's aggregate the data, separate out by race and ethnicity so we can really know where we are in terms of our dealing with these particular situations. So standard measurements, standard accounting across the board. Pretty simple. Number two, we need to study. We need to study women. We need to study what's going on. For too long, the thought was if she's female, all you have to do is, ignore the breast, ignore the reproductive organs, and she's just a little man. And anything that applies to men should apply to her. Recently, we've been finding that this is not necessarily true. Women are not just little men. We sometimes respond and react differently. So we need to do studies on women. Makes sense. And so I agree with this, but I want to add that given our history in this country, we need more than just recruiting Black women to be participants in study. We need Black women, Black professionals who design, oversee, and analyze these results. We need to be more than just participants in the clinical trial. We need to be active designers of what gets studied and how it gets evaluated. Number three is care. We need to be able to provide care for pregnant women. And that sounds like a no-brainer, but consider this. Medicaid is the single largest payer of maternity care. When you look at the Medicaid reimbursement for total obstetrical care and compare it to commercial reimbursement for the same service, there is a significant difference in what gets paid out. A significant difference. Now, most of the times there is reluctance to share numbers, but it's been said that the commercial reimbursement is often twice twice what the Medicaid reimbursement would be for comparable care. So you have to wonder, why would an OB choose to take care of a Medicaid patient when they could see a commercial patient and make almost twice as much? And we know that as a result of many factors, there's been a decline in the number of OBs in this country. There's a decline in the number of OB/GYN residents in this country. And can you wonder why, when we live in a political climate that makes it difficult for OB/GYNs to do what they were trained to do? Is there any wonder that we have decreased OBGYNs who, and those that are there, most likely would prefer not to have to deal with Medicaid patients because of the bureaucratic paperwork that comes along with the low reimbursement? And so you have a situation where there are declining numbers of professionals that can care for the pregnant women. There's very little incentive to want to care for pregnant women. My thought is that we need to redo it all. We need to have a whole new approach. We need to embrace things such as group prenatal care and birthing centers. And that's a whole nother podcast that I would love to talk to you about. But right now, we need to understand that the medical system is broken and women are struggling to find providers, doctors that can take care of them. And doctors are struggling against administration that makes it hard for them to do what they were trained to do. So here we go. The first thing was count. Let's standardize all of our measurements when we're talking about maternal health. Let's study, but let's include Black persons in the design, oversight, and the review of studies, not just have us as participants. Three is care. Care is a big problem, but we need to consider the fact that we will now reevaluate and recreate a better system that can deal with our current environment. Number four is include. We need to be inclusive. We need to have cultural competency when we're dealing with patients that don't look like us. I had a personal experience this year where it was clear that this doctor lacked cultural competency and was very dismissive. And so my recommendation for this is similar to what happens every 2 years when doctors have to renew their medical license. There is continuing medical education that they are required to undergo to demonstrate that they've done over that 2 year period. There is a standard requirement that it include knowledge or reading about the opioid addiction and also about child abuse. I would add cultural competency as a required CME that needs to be done every 2 years as we undergo medical license renewal. It's a start. It's a way to make people aware because, for instance, I'm sure that doctor I mentioned earlier doesn't believe he's racist. Most doctors would not say, "Oh, I think I'm a racist." Most healthcare systems won't say, "We engage in racist practices." But maybe with the repeat education, they will start to understand where they can improve. And the last thing is invest. Invest, meaning put money into female research, put venture capital money into services and products and tools that can help to advance women's health care. Now, granted, venture capital funding often involves digital tools or biological innovations, and investing in healthcare may be a bit of a stretch, but we need to be creative about this. And we also need to understand this very shocking fact that 0.1% of venture capital funding goes to Black and Latino women. And do we believe that it's because there are no Black or females that have ideas? I'm here to tell you that we're here. We're here. We have ideas. We just need for you to open the door and be receptive to us. And so those are the 5 things. Um, pretty straightforward. Pretty straightforward. Count. Make our measurements, our standards, our uniform across the board. That should be fairly easy. Study women. We're not little men, but include Black persons, people, but include us in the design and the review of these studies and the oversight of these studies, especially given our history. 3 is care. Care is a big problem, but we can do it if we're willing to step outside of what has been and consider more innovative programs such as group prenatal care, where women get empowered, where women form communities. Again, I would love to talk about that more. 4, be inclusive, include, have our current healthcare providers, our current healthcare systems undergo repetitive and repeat cultural competency training. Make it a requirement. And lastly, invest in women. Those steps sound pretty simple. It's going to require all of us being invested in seeing an improvement. And why should we? Well, the report started off by saying, given the reason, we should because we all benefit. Other women benefit as we improve the healthcare system for women. And with decreased illness, with increased productivity, we can see economic boom, and we can all benefit from that. And what's so bad about that? I'm Dr. Rahman saying it was a enlightening study. Please take the time to share your thoughts. Let me know what you know. Let me know what you think about these 5 suggestions. Let me know what you think about what I had to add. I love to continue this conversation. It's always good when people come together, not just to complain and bemoan the situation, but when people come together with ideas and solutions and goals and commitments. And so I say until the next time, take care.